I'm presenting new data from our research group. It's a research consortium, and what we developed is a newly designed overtube system, and that was made and constructed by 3D printing, so very new, exciting technology. And we took advantage of that new technology for interventional endoscopy. When you do interventional endoscopy, you also do endoscopic submucosal dissection. That's a very fascinating and new technology for therapy of early gastric cancer or neoplasms in the rectum. The problem with that technique is that it's rather complicated, it's cumbersome, and it's also risky. Even the super experts have perforation rates of about 8%. So we thought that it might make sense to have a system that enables you to, well, use instrument as we use when we have lunch, as I just had. You have one arm where you grab the tissue, and then you have another arm where you cut the tissue. And that's the big difference in comparison to standard ESD, where you have only one arm and do the dissection with only one instrument. I think the big advantage we have, that why we have this new technology, is that we didn't have 3D printing before. And now we have 3D printing, and I think it's a new technology that, I don't know whether it will revolutionize our lives, but it's certainly something that will become very familiar within the next years. And I'm very certain about that we also that it will be more and more transferred into medical practice. And this is something new. The good thing is that the stomach is rather big. So in the stomach we have quite some room. The good thing is, because it's a 3D printed system, we can also easily adjust the system. So we just decide to make the arms at the tip of the overtube a little shorter, or make them larger, or make the overtube system smaller, make it shorter, make it longer. So that's a big advantage of that new 3D printing technology, that we can really sort of individualize our instruments. That's what we are planning, that we have some sort of various models that you, depending on the sort of procedure maybe you do a radioscopic resection in the stomach, your system will differ from that you use in the rectum. If you do it in the proximal part of the colon, the cecum, it will also be different from what you do in the esophagus. So we really think about constructing various models for various indications, and not really individualize it for the individual patient, but have a whole selection of various overtubes that can be easily printed by 3D printing. We didn't treat any patients so far. We're planning to start our first patients by the end of the year, because we have to CE mark it, and at least for Europe. And so far we treated only animals. But doing that we were quite successful, because the standard procedure that usually takes you about at least an hour or 45 minutes, we were able to manage within 15 minutes with that system. We expect to have it a safer procedure as the usual procedure, because you can really lift the tissue before you cut it, so the risk of perforation is lower or not at all. The only problem that we might generate is that by using an overtube, it's thicker as a normal endoscope. So there might be some problem passing it. So far at the animal, this was not really a problem. If you use it in the rectum, it's no problem at all, but it could be a small limitation as soon as you start human trials. If there is a very narrow throat, that might be some limitations, but that should be it. And if you compare it to the endoscopes we've used 20 or 30 years ago, that were standard endoscope, it's not thicker as the standard endoscope.